everybody. I'm Jenny Phillimore from the Institute for Research in Superdiversity at the University of Birmingham, and I'm joined today on the IRIS conversation by Sara Hamed and Suruchi Thapar-Bjorkert from the University of Uppsala in Sweden. Sara Hamed is a dentist and a PhD candidate at the Department of Sociology at Uppsala University. And her PhD research is on racism and healthcare, but she was also a researcher on the upward study that looked at healthcare seeking in super diverse neighborhoods. Suruchi Thapar-Bjorkert is docent and senior lecturer at the Department of Government at the University of Uppsala, and she's in the process of completing a Swedish Research Council funded project with Hannah Bradby, with Sara and with Beth Maynard Alberg on understanding racism in healthcare, developing and implementing an anti-racist strategy through shared knowledge production and evaluation. So I'm happy that they've both agreed to talk to us today about racism in healthcare. And I'm going to start by asking you, well, what does racism look like? How does it manifest in healthcare?
I think to understand how racism manifests in healthcare, one needs to understand the context in general in the society, in European societies, and also the context within healthcare. So I think that racism is a very politically loaded issue, and usually conversations around racism are fraught with difficulty. And then there is this idea in Europe that since we already have established that race is not a real biological category and that it's a social construction, that because of that, racism no longer exists. And so then when acts of racism happen, they are usually seen as individual shortcomings. And so racism is individualized. So this context of the difficulty of talking about racism makes then the experiences of racism and the processes of racialization invisible because there's no space to talk about it. And then within healthcare, there is something that we call healthcare exceptionalism, because healthcare providers see themselves and see healthcare as this rational institution, which is based on natural science, and it's based on medical knowledge, and so feelings of bias don't really have a place in healthcare. I mean, that's the assumption. And so again here, because of that assumption, when racism is seen as a breach to the core ethics of healthcare and therefore not talked about, and again, when it happens, it's seen as an individual aberration. So this lack of space to talk about racism in the society in general and within healthcare renders invisible the processes of racism and the experiences that people do have, both healthcare users and healthcare professionals.
And the invisibility of racism in healthcare, it contributes to the persistence of racism, and this could also explain why racism is often left unexamined, or as Sara just pointed out, moved towards looking at it as individual shortcomings. So I think that to understand the complexity of racism, its invisibility, its obfuscation, it is important to understand how these work on the one hand, but also the material consequences that shape the risk of morbidity and mortality. And here, I think it's important to emphasize that both the trivialization and obfuscation of racism contributes further to the perpetuation of healthcare inequities. So in our research, we could delineate sort of three interconnected ideas to your question, Jenny, here. That first, how racism as an institutionalized social structure is enacted through human practice in subtle and invisible ways. The second idea is that how structures and stratifications of inequality which underpin racism are normalized, naturalized, and taken for granted. And the third idea is that how these structures, which systematically disadvantage racialized subjects, can coexist with care. So, looking at the intersections of these three ideas, one could also conceptualize this theoretically um, through an empirically underexplored concept of structural violence.
So we've got three interacting kind of mechanisms that are perpetuating racism, and these are quite complex and they're long embedded. How do we take a healthcare system and address these problems? What can we do to make a change? Because it is quite, as you say, it's hidden. And when something's hidden and when it's complex, it makes it exceptionally difficult to deal with.
Yeah, and from the data from our interviews with healthcare professionals, they do talk a lot about this lack of space, although they experience racism, but there's a lack of space to talk about racism. So I think the first step would be to make visible those processes of racialization. So the first step would be to talk about it. So even in our project that we're doing here in Sweden, we've started teaching about racism in healthcare to nursing students, for instance, and that was the first time that they've ever talked about racism, right? And from those different seminars that I've had with the nurses, they all, I mean, all of them mostly talked about having experienced racism or seen racism by patients towards healthcare providers and so on. So through talking about racism, we were able to render those processes visible. So I think that is the first issue, because if we go back to this idea of healthcare being rational, I think one of the issues is that there's usually a document that talks about the importance of equality in healthcare and that we're not allowed to discriminate and so on. I think those documents exist everywhere. But the problem that we found in our research with those documents, that because they exist, racism is rendered invisible, because they act as a way to say this institution of healthcare cares about equality because we have those documents. So don't come here and talk about racism. We already have an equality document, right? So then the equality document becomes non-performative. And I think talking about racism and naming racism, so not just talking about equality, but naming racism would be at least the first step forward to dealing with the issue.
What would you say, Suruchi?
And also, I think it's just to sort of carry on from what Sarah is saying in relation to your question, Jenny. I think that we need to look at or understand the practices within healthcare and the kind of even though as we all agree that the workings of racism um, could be subtle, could be invisible, but we still need to understand it through the practices within healthcare. And two of the kind of big issues that arose from talking to particularly healthcare users, but also to some extent healthcare providers, was first the silencing of suffering, and which was also related to the inequality in access to power and resources. But the second issue also, which is very important, is the erosion of dignity. So when you look at issues of silencing of suffering and the erosion of dignity, you can start seeing the impact of the subtle workings, the material impact in relation to health of ethnic minority populations.
Yeah, and just to add to that, sorry, with the subtle nature of racism in healthcare, that I think in healthcare it is still viewed, racism is still viewed as this direct type of racism. If the N word is used, or if those derogatory racist terms are used, and are not seen as something, like Suruchi says, structural, that is embedded in the different medical routines. So that is also a shift that needs to be emphasized within healthcare, how to see racism today.
Yeah, and also in relation to that, I think that institutions, so for example, in our conversation here, the medical institutions can nurture environments where medical staffs view certain practices and relationships as part of a normal medical routine. And with time, these practices, but which can be seen as disempowering by the patients, and to some extent by the healthcare providers, they become embedded in the culture of, let's say, a clinical setting, and become routinized. And I think that's what's important, that it becomes as part of the normal working medical environment, which then again contributes to the invisibility, to invisibilize the workings of racism.
So what is needed then is a process by making visible all these kind of micro aggressions and racisms that are not so obvious, both to the general population, to policymakers, but also to providers themselves. But it sounds like, going back to what you said, Sarah, there's a need for education. So you're starting to work with nurses. How widely is this idea that we could educate about racism and should educate about racism accepted, or is your work the exception rather than the rule?
Well, in Sweden, it's the exception. I think this is the first time ever that there had any education about racism in any medical educational setting in Sweden. So this would be the first time, yes. So usually there is education around, again, equality. Equality is usually talked about as gender equality, not so much racism or racial equality. But yeah, there is no discussion around racism. And I think every time I ask, have you ever talked about racism? I mean, not even in their workplaces do they talk about racism officially. Maybe a little bit with other providers during the coffee break. But there's no official discussion. So yeah, in Sweden, this would be the first time.
And so does this mean, do they have do health providers do they have the language they need to have these conversations?
No, they don't. Not just in healthcare, but generally, that there is a lack of language, and that's one of the reasons why we started the project. We talk about there's no language generated around racism in healthcare in Sweden, because the difficulty of talking about racism. So again, they talk about equality. That's the language that is used, but not racism, and maybe they use the word discrimination sometimes. Yeah, so even discrimination does not exist as a category for reporting at all for both patients and healthcare providers. So if you want to report an incidence of racism, for instance, if you're a patient who's experienced racism, then you can go to something called the Patient Advisory Committee, but they don't have discrimination as a category of complaint. So it ends up in different categories, and so then it makes it difficult to generate data. Yeah. So there are different layers of invisibility. So it's invisible in the legal system, it's invisible publicly because you don't talk about it, although this is changing a little bit after the Black Lives Matter and the COVID crisis. And there is also no data generated around or around race in general, because it's illegal to gather data around race in Sweden.
Yes, and there is like just kind of sort of affirming what Sarah said. There is a lack of any sort of routine statutory data on ethnicity or race, and in relation to the conversation that Sarah was talking about of health exceptionalism, I mean that sort of is a trajectory that we can draw from the construction of Swedish exceptionalism. And even in Swedish exceptionalism, because Sweden detaches itself from any reference to a colonial past and emphasizes the gender equality lens. So if they are doing gender equality work, they see that as completely fine. Um, and that's what they should be doing. And that's why the conversation around racism is then very difficult to raise in these settings. So in some ways, Jenny, you could say that racism starts masquerading as gender equality work.
Yeah, and it's not just Sweden. Like we've done a scoping review in the project, looking at empirical articles that examines racism in healthcare and globally, and you can see that most of those articles, of course, are conducted in the United States, focusing on African Americans, and then in Europe, there is research mostly from the UK. But not so much as you would think. That is research looking at racism within healthcare. And although in the last 2 years you see more research coming from Europe, like France, Belgium, and even now Sweden, generally there's not a lot of research on racism in healthcare in European settings. And I think that is because, again, of this, that racism is a politically loaded issue. So it's even difficult to do research around racism in academia, and then even more difficult to navigate the healthcare system as well. Yeah.
Well, if we're not creating evidence about it, then it makes it even harder to fix it.
Yeah, exactly.
So in terms of scholarship, then perhaps this is something that we really need to pay much more attention to.
Yes, and also one observation is within the academic practices is that even discussions around racism get clustered into very race-specific symposiums or race-specific conferences. It is something that is seen to be sort of discussed separately rather than something that flows through the everyday discussions in social sciences. So even within academia, you find that that you would get a special call for race to discuss racism rather than just seeing it as any other form of inequality.
Yeah, and I would just like to add that when it comes to the research on racism in healthcare, it is mostly conducted by public health professionals or healthcare providers, right? So it's mainly descriptive in the sense that it just documents experiences of racism rather than trying to understand how it works. So for some reason, social science has not been looking at racism within healthcare, at least empirically.
So this makes the project that you're working on particularly important. Just as we finish off here, can you envisage a way that you can take your findings and actually ensure that the conversations are kind of rolled out more broadly and that changes can happen? So maybe that you can have some impact both on scholarship, but on the way in which healthcare services think about racism.
I think it's in response to that, I think that the first thing that we are trying to do is to basically evaluate the institutionalized practices in healthcare, and to evaluate them critically with the aim to generate meaningful new knowledge about how these practices um, can be reversed or can be done differently. And once we create that meaningful knowledge around this, I think that the stage at where we are, it is about knowledge, this converting this knowledge um, into action. So Sarah and Hannah and Beth, they have been, and Sarah pointed this out earlier, have been engaging in intervention programs and through teaching and changing the perception of healthcare providers.
Yeah, and also more broadly, because we're not just looking at experiences of racism, we're looking at the way, in my PhD project, I'm looking at the way healthcare professionals reason around racism. I think that would be a contribution to the broader context, yeah, because then we're looking, for instance, right now I'm looking at different ways of denial when it comes to racism. And I think that's important in general. So we're looking more into theory as well, to the research around racism, not just like specifically on the Swedish context.
I think what you've done is you've shown us how important it is to bring a social science lens into practices, everyday practices, and that theory is absolutely necessary to understand what's going on and be able to construct a way forward to to generate change. So thank you very much for your time.
Thank you so much. Thank you for having us.